Good afternoon, everyone. It's 12 noon, so we'll get started. Before we start our presentation today, just a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. Thank you for coming to Medical Grand Rounds. Our speaker today is coming to us from the Division of Gastroenterology. So thanks to the gastroenterology team for inviting Dr. Bardou. Just a couple of comments about the presentation today. First of all, please remember to answer a brief survey at the end of this presentation. As well, please enter your questions in the chat after the presentation is done. But unlike usual rounds where we save all the questions and comments till the end, Dr. Bardou has asked us to have more of an interactive medical grand rounds today. And we'll be asking questions along the way, and we'll be wanting answers. So during the grand rounds, I hope you will all participate and answer the questions Dr. Bardou will be asking us, and you can put those answers in the chat, and then I will let Dr. Bardou know what those answers are. So as a way of introduction, Dr. Marc Bardou is coming to us from France. He is a gastrohepatologist and a professor of pharmacology médicale, so medical pharmacology at the CHU de Dijon. He holds a master's degree in health services policy, and he has multiple research interests, especially on the impact of inequalities, social inequalities, and economic environment on the healthcare system. And this is where he's become interested in these cognitive biases, especially with respect to underprivileged people. And his presentation today is really on the role of these cognitive biases in the decisions that we make in the healthcare system. So, Dr. Bardou, bienvenue aujourd'hui. Merci beaucoup d'être ici avec nous et je vous laisse la parole.
Merci, thank you. As it has been said, I'm really expecting, so I'm going to share my screen. I'm really expecting that during the phase where I will be asking some questions, you try to answer this question because those questions are there to illustrate the fact that we all have cognitive bias. So that means I'm expecting that you're going to respond to this question as fast as possible. And so those are very simple questions. So I will be asking some numbers, for example, some probabilities, say which one do you prefer? So these are quite questions. The talk, we are first going to listen to an audio recording of a woman who called the emergency department. That was 5 years ago. And unfortunately, this 22 years old woman passed away. And as you will see, this is an extraordinary example of implicit bias. And unfortunately, those biases have led to the death of the patient. So we will be listening to this audio recording. Then I will be, first of all, asking some questions just to increase your awareness of the implicit bias. I will be presenting the most relevant implicit bias, and then we'll be re-listening to the audio recording, and I would ask you, based on what you have heard from this presentation, what kind of bias you can identify in this audio recording, in this interaction with this woman, with the emergency department, which may have led once again to this very negative outcome. So I'm going to start the screen sharing, and during the audio recording, I will ask you to put your headphone on the maximum because the level is not that high. And also, I'm sorry, but the recording is in French. I didn't have the choice. So I'm sharing my screen. So can you see my screen correctly?
Yes, we can.
Yes. Okay. So let's move on. So we're going to discuss the role of cognitive bias in healthcare decision. So this is a title of an article in the French newspaper, national French newspaper, saying that a family wonders after the death of Naomi, who died after a call to the SAMU, so the emergency medical services. You know that in France, at least at this time, we didn't have a unique number. So we had several numbers to call the police, the fire department, the emergency department. And this woman called first the police, and the police transferred the call to the SAMU, so the emergency medical services.
Accueil SAMU du CTA, ne quittez pas, le permanencier du SAMU 67 va vous répondre.
I'm stopping the call just to let you know that you need to listen very carefully, not only to the words, but also to the tone of the discussion between the two operators.
Accueil SAMU du CTA, ne quittez pas, le permanencier du SAMU 67 va vous répondre. C'est la police de l'ordre. C'est pas 80, hein. Le CTA pour nous aussi. Ça, tu vas en médecin. Moi? Oui. Non. Je te charrie. Dis-moi, donne-moi le numéro. Alors, mais, enfin, non, mais la dame que je vous disais, c'est ce qu'on lui conseillait de faire, en fait. C'est vrai? Ouais, elle a appelé la police, alors, parce que là, la grippe, je sais pas, mais elle m'a dit qu'elle va mourir. Oh, mais ça s'entend, hein, elle va mourir. Allez, dis-moi le numéro. Alors, au 06 66, ouais. 82 67, ouais. 41. 41, ok. Strasbourg, 10 rue de la Tumeno. 10 rue de la Tumeno. CH. Hein? CH. Ah, CH. Ouais, mais je cherche. Tumeno, ouais. Au troisième étage. Ouais. Alors le nom, j'ai compris Musenga, M-U-S-E-N-G-A, je lui ai été appelée après, maintenant. Ouais. Elle a 22 ans, elle a des douleurs au ventre. Ouais. Bon, la sérène, mais c'est pas ça, apparemment. Ouais. Elle a de la fièvre et elle va mourir. Ah, ouais, c'est sûr qu'elle va mourir un jour. Certain, faut qu'il meure. Ah, ça marche. Ça va. Ouais. Oui, allô? Allô? Oui, qu'est-ce qui se passe? Qu'est-ce qui se passe? Bon, si vous ne dites pas ce qui se passe, je raccroche, hein? Madame, j'ai très mal. Oui, bah vous appelez un médecin, hein? D'accord. Voilà, vous appelez SOS médecin. Je peux pas. Vous pouvez pas? Ah non, vous pouvez appeler les pompiers, mais vous pouvez pas. Oui, vous allez mourir. Simplement un jour comme tout le monde. Ok. Vous appelez SOS médecin, c'est 03 88 3 fois 75. D'accord? Vous avez compris? 03 88 3 fois 75. Bah, je vais pas vous aider, je sais pas ce que vous avez fait. J'ai très mal. Oui, et j'ai très mal au ventre. Oui, vous n'avez pas au ventre. J'ai mal partout. Oui, bah vous appelez SOS médecin. 03 88 75 75 75. Voilà, là, je peux pas faire à votre place. 03 88 75 75 75. C'est un médecin vous voit, ou sinon vous appelez votre médecin traitement. D'accord? Voilà, au revoir.
So this woman, so the emergency, an ambulance was not sent to her house. She called the medical services again and again. She was finally admitted to the hospital, and she died because of small bowel infraction, which we don't know, but she may have been saved if they had not lost many hours not taking care of her. After this call, I published with one of my colleagues an article in a newspaper saying that, because after this case, an inspection was conducted, and they made some conclusion, but they absolutely did not consider the fact that there were some implicit bias. So what are the cognitive bias? What is the definition? The cognitive, when you make cognitive error, it's a mechanism of thought which may cause deviation in judgment. And cognitive bias is when you have this systematic deviation. So meaning that in the same situation, you will always make the same error, and you may have the same deviation from logical and rational thinking from reality. It has to be well admitted that it is at the unconscious level, meaning that you do not that purposely. It's something that is beyond your level of conscience, and so it's much more difficult to avoid this bias. The cognitive bias, those are the difference between what I believe I think and what I really think. This was illustrated in this study where health professionals were asked about their race preferences or their social preferences. In light blue, you have the explicit preferences. So that means that what the people answered at the conscious level. And in dark blue, you have the implicit preferences. And what you can see here is that for race preferences, most of the physicians explicitly expressed that they had no race preferences, sorry. And when you look at the implicit level, that was almost exactly the opposite, and a quite significant proportion, more than half, had either moderate or strong preferences for white patients. For social class preferences, the explicit preferences was that most of the physicians expressed that there are some kind of preferences for the lower class patient. But in reality, when this was implicitly assessed, almost all of them had a quite significant preference for the higher social class patient. The point is that you may know that we have two levels and two systems of thought, and Daniel Kahneman was awarded the Nobel Prize of Economy a few years ago working on that. So we have the system one, which is the heuristic system, fast, unconscious, automatic for everyday decision, but it is error prone. And you have the second system, the algorithmic system, slow, conscious, effortful for complex decision, and is reliable. And the inhibitory system has to interrupt the heuristic system to activate the algorithmic system. The point is that you may know things, but even knowing that, sometimes your brain cannot manage that. So now we're going to go through practical example. Here you see two lines, one at the top, one at the bottom. Please answer as fast as possible which one you think is the longest. Upper, lower.
So we have answers here that top looks longer, and then a few that say same length. So we have a mix. Look, more people. Well, it's kind of half-half. Same length or top looks longer.
Okay. So if you look at exactly the same size, and if I go back, even knowing that one is they are the same size, your brain has difficulty in accepting that they are exactly the same size. Some practical examples. So let's assume that you have water lilies on the surface of a pond. The area covered doubles every day. On day 30, the whole pond is covered. On what day did they cover half of the pond? Please answer. I'm expecting to see a number.
We have number 29, 29, 29, 15, 2 15s. It's a mix, 29 and 15.
Okay, so by the correct answer is 29. So those who answered 15, they used their system 1, and those who answered 29 use system 2. It takes 5 machines 5 minutes to make 5 widgets. How long does it take 200 machines to make 100 widgets?
We're getting 5 minutes. Everyone's saying 5 minutes here.
Okay, that's of course the correct answer. Now we're going to watch a video, short video, and I'm asking you to count the number of passes of people wearing a white T-shirt. Okay, remember you need to count the number of passes of the one wearing a white T-shirt.
This is a test of selective attention. Count how many times the players wearing white pass the basketball.
So how many passes did you count?
Okay, we have 11, 15, 16, 12, 10, 17. There's a lot of different answers. 13,
Okay.
12, lots of different answers.
Okay, and now the answer is who saw the gorilla? The one who saw the gorilla, please raise your hand.
Okay, we do have some yeses, we have some no's, but we do have some yeses there.
Okay, so that means that roughly half of the people do not see the gorilla. And this is the bias of what we call selective attention. So that means when you pay attention to something, you may miss things that are really obvious. And this is one of the bias that may be driving your fast decision. Another practical example, heads or tails. So you flip a coin. You're going to flip a coin once only. If that's heads, you lose $100. What is the minimum amount of gain that you would like to have if that's tail to accept to play the game? So remember, flip a coin, only one attempt. Head, you lose 100. What is the gain you're expecting on tails to accept to play the game? So please answer, what is your minimum expected gain to accept to play to flip the coin?
Okay, again, we're getting quite varied answers. None, 100, 1,000, quite a few 100.
Exactly. And so this is the classical bias of being not prone to lose. In fact, if you flip the coin only once, if you lose, irrespective of what is the expected gain, you're going to lose 100. And if you gain, you're going to gain 10, 100, whatever. So that means there is no good answer. And the one who have expressed that they want to have a gain which is much higher than the potential loss are the one who has who do not want, who are do not accept the likelihood of losing something. So now we're going to go through some of the most classical bias, and I'm going to go into details. There are some very well known, and we're going to discuss them, which are the unsharing bias, the availability heuristic, bandwagon effect, and conservative bias, confirmation bias, clustering illusion, choice suppursive bias. This is a taxonomy of all the bias. Can you read it? No, I'm sure you can't, and neither can I. The point is that it's just to express the way that there are thousands of bias, very complex. Sometimes they are very close to each other, but really we are full of cognitive bias, and those bias have an impact on not only on the medical decision making, but also on many of the decision we make in the daily life. And remember that the FAST system, the heuristic system, the one who is the most prone to error, is the one that you use in your daily living activities. So now we're going to, I'm sure you know this picture. We're going to discuss the survivorship bias. So remember, during World War II, England was sending planes to bomb Germany. When planes were returning back from Germany, they had bullet hole. They were losing planes, and to avoid the loss of plane, they decided that they needed to reinforce some of the places, some of the part of the airplane. To your opinion, which part of the airplane do you think needed to be reinforced? Any clues?
It says here, yes, there's quite a few. The body, the ones where I sit, the ones which were not hit. Middle where the pilot is. The tail,
So,
all of them. So many answers.
Okay, so this is the survivorship bias. So by definition, the plane which returned from Germany were the plane that were not hit in a strategic part of the airplane. So those are the survivor. And by definition, the recommended area to reinforce were, of course, the area with that bullet hole, because the assumption was the plane which were hit in this area where the plane which did not return. This is what we call the survivorship bias. And so the survivorship bias is a form of selection bias that overestimates the chance of success of an initiative by focusing on successful but statistically exceptional rather than representative cases. So if you do something once and you are successful, you may not remember all the other cases where in fact you failed. And so you're only going to remember the success. And this is a very, very classical cognitive bias. The second bias is the base rate negative bias. So once again, I'm going to ask you one calculation and one answer. So we have a disease which affects 1 in 1,000 people. We have a test with a specificity of 95%, meaning that the test is falsely positive in 5% of the cases. If a person tests positive, what is the likelihood that he or she will become ill? So what is your answer? I'm expecting a proportion.
Uh, 95 positive predictive value, 94 seems to be getting 95s, and we don't know.
Okay, so most of you answer. So 95%.
95% is the most common answer.
Okay, and the correct answer is of course 2% and 95%. Let's make the calculation. Assume a population of 1 million. Disease prevalence is 1 out of 1,000. So if you have 1 million, you have 1,000 person really ill. The test are 5% false positive. So that means that you are going to have 50,000 false positive. So you have much more false positive than real positive, meaning that the proportion is 1,000 out of 50,000. This will change if the disease prevalence changes, of course. And this is something that is very commonly misunderstood. And I'm sure that you do not trust my calculation at this stage, but you will think about this calculation and try to figure whether or not you agree with this answer. The answering bias. So this is, I think, maybe one of the most severe or most frequent bias is when we have difficulty getting rid of first impression. Subject to the answering effect, our brain will tend to rely on the information it received first and will be influenced by the decision it will make later. So that means that once something has entered your thought, you can not skip that. One example is if you ask people, okay, what is the color of cloud? What is the color of snow? What is the color of cotton? They will answer white. And then you ask, okay, can you tell me what the cows are drinking? And many people will answer milk. Of course, cows do not drink milk when they're adults. Because of the white color, you have answered the brain to the fact that we are driving to something that is milk. For the French people, if you ask, okay, how do you say N-E-W in English? They will answer new. And then you ask, what is the capital of the United States? And many people will answer New York. So that is the answering bias. The self-indulgent bias is referred to the tendency of people to attribute the causality of their success to their own quality and their failure to the outside their control. So if you succeed, you pass the exam, it's because you work hard. If you fail the exam, it's because that was too difficult or because they were trapped. The premature closure bias. So this bias is when you're going to collect information, sometimes based on the frame. Once you have collected some information, you will stop, in fact, considering the other information. So that means you have made your diagnosis, then you close your way of thinking, and you will not reconsider your work diagnosis. This is the case of a 52-year-old male patient with metastatic gastric cancer, who was brought to the emergency department because he had abdominal pain, distension and discomfort. The diagnosis was promptly closed as peritoneal carcinomatosis because of some of key finding and because of the history of gastric cancer. And in fact, they did not consider the fact that the gastrojejunostomy had moved and was inserted into the peritoneum. And when it was removed and the fluid was removed, then the pain disappeared. So this was a premature closure because they knew that this patient had cancer, this patient had abdominal pain, and that was gastric peritoneal carcinomatosis. The confirmation bias. So we've discussed the premature closure. Premature closure is when you have selected, you have collected a given number of information, and once you've made your diagnosis, you stop collecting any other information. The confirmation bias is that you have reached some kind of diagnosis, and you're not going to close the collection of data, but you're only going to collect and consider data in favor of your desired hypothesis and ignore all the evidences that are not in line with what is your primary diagnosis. The evaluative bias, it's a bias which is also very significant and very impactful in medicine. The evaluative bias or availability heuristic refer to the tendency of people to rely on information that is easier to recall rather than which is necessarily most representative when faced with a decision. One example is that, so you were working at the emergency department last week, and someone came with chest pain, and you did not order CT scan or MRI to make the diagnosis of pulmonary embolism. Your patient died because of pulmonary embolism, and for your round on your next day in the emergency department, you may order an MRI or scan for every single patient with thoracic pain, because you would think that those patients may be having a pulmonary embolism just because you have this evaluative bias, because this diagnosis is really the first diagnosis, and you have a very accurate memory of this example. The overconfidence bias, or the Dunning-Kruger effect, is a cognitive bias whereby people with low ability expertise or experience regarding a certain type of task or area of knowledge tend to overestimate their ability or knowledge. This has nothing to do with being smart or not smart. It's just the overperception, overconfidence. And if you look on this graph where you have the confidence low, high, and the competence know nothing and guru know everything, you have what is known that the peak of Mount Stupid, when you have very low competence and very high confidence. Then you have the Valley of Despair when you're starting to gain competence, but you're losing your confidence. And finally, you will have a good correlation between your competence and your confidence. I'm going to discuss the framing bias. So this is one example. So the framing bias is also a bias which may have very significant impact on your interaction with your patient. It's a way to say that the way you're going to ask the question to a patient may have a very significant impact on the answer you're going to collect. So this is in French, but that will be easy to translate. So this is a report on the people who say that they had a renouncement of care for financial reasons. So here you have in dark red, those are the most deprived patients. In dark orange, people who, dark red, those are the most favored patients. Orange, those are patients who are somehow deprived, and yellow or light orange, people who are the most deprived. And you can see that there is a correlation between the level of deprivation and the renouncement to dental care, to the purchase of glasses, medical encounter, and other care. So you can see that for all type of care, the patients who are the most underprivileged have the highest likelihood of renouncing to care. Now this study assessed the answer based on the way the question was asked. So there were 4 ways to asking the question. First, the financial reason may be asked upfront, and the type of care may be asked upfront, or you can ask the type of care secondly and ask the financial reason upfront. No specification, so neither for the financial reason nor for the dental care. And then no for financial reason and dental care, and no financial reason, no dental care. So to make this clear, here the question asked was, did you renounce to dental care because of financial reason? And here the question asked was, did you renounce to care? And if the patient answered yes, the question went then asked, did you renounce to dental care? And did you renounce to dental care for financial reason? And you can, so here this, did you renounce to dental care because of financial reason? Did you renounce to care? And then after you ask the reason and the type of care. And you can see that depending on the way the question is asked, the answer, there were 15% less absolute reduction of people answering that they renounced to dental care because of financial reasons, based on the way the question was asked. So this is what we call the framing bias. And so this is a way to say, okay, be very careful when asking different questions to your patient. The halo effect that we're going also to look at is very important in medical decision. So the halo effect or notoriety effect or contamination effect, it's a cognitive bias that affects the perception of people around. It is selective interpretation of perception of information. So the way people are being dressed will influence what you think about them, how you're going to interact with them. This is close to the stereotyping or attribution bias, where in fact, you're going to make assumption based on patient. It depends on what are your bias, but you may consider that people with some type of clothing may be criminal, or you may consider that some subgroup of patient, for any reason, may be overexpressing pain, maybe overexpressing anxiety, maybe overexpressing whatever you want. This was assessed in a study published 13 years ago, where physicians were exposed to vignettes with 4 types of vignettes, and this question was based on the recommendation for intrauterine contraception. So 4 vignettes. So one white girl dressed in what we may call low socioeconomic background, white girl with clothes of high socioeconomic background, black girl with high socioeconomic background clothes, and black girl with low socioeconomic background clothes. And what you can see here is that based according to the way the women were perceived, so becoming to a lower class or upper class, and you have a very significant difference in the recommendation that were made for the intrauterine contraception. So it means that even if you're following recommendation guidelines, you may be influenced by your perception of someone, and this is based on nothing. So this was only, so no interaction, this was only pictures. So that means that your first impression will have a very significant impact on the way you're going to manage the patient. I'm running fast. This has a quite significant impact. Once again, a study that was published 16 years ago about the multivariate logistic regression for the analysis for treatment with non-standard regimen. And what was observed was the people belonging to the Black race were almost 2 times more likely to receive non-standard regimen than people to the other races, and people and the education level was also very significantly associated with the likelihood of not receiving a standard regimen. So the conceptual model of the influence of implicit bias on disease control. So you have the physician may have implicit bias. So the physician perception and judgment on the patient may have an impact also on the patient perception and judgment. So if you have implicit bias, which may lead you to interact quite rudely with your patient may perceive that and may have a modified adherence to treatment, and the physician, based on his perception of bias, may have impact on the interfaceification of treatment, of management of treatment, and this can have an impact on the control of the disease. So most people are not aware of their own implicit group prejudice. So implicit group bias resides in unconscious mind, the part of the brain that many researchers believe is beyond our direct control. The unconscious attitudes are less egalitarian, and we have seen that at the very beginning of the discussion, than what we explicitly think about the group. And our refusal to talk about and confront group issues, race, socioeconomic status, reinforce the implicit group prejudices. We're close to the end of this talk. So this is a brief summary of the main implicit bias that may be involved in health. So the availability error. So when a clinician estimates the initial probability of disease based on recent experience rather than the real probability of the disease. Misrepresentation, when you assess the likelihood of disease based on the consistency of available data with the classic manifestation of that disease without considering its prevalence. The premature closure error we have already been discussing, the entering bias when one clings firmly to an initial impression even as contradictory data accumulate. The confirmation bias when clinicians selectively accept clinical evidences in favor of the desired hypothesis. The attribution bias, negative stereotype that lead clinicians to ignore or minimize the probability of serious illness. Emotional error, when that's the avoidance of unpleasant but necessary tests because of affection of sympathy for the patient. Overall bias and the frame bias that we've already been discussing. So now we're going to listen once again to the call to the emergency department, and then I will ask you, and if you cannot answer, I will drive you to and try to capture what are the bias that you can think had a negative impact, a very negative impact to what happened to this woman. So remember, the call is between the operator from the police department, the operator from the emergency medical service, and they chat together at the beginning, and then that's the operator of the emergency medical department who is discussing with the woman. She was a trained operator. That was a call early in the morning. So when she has just started a round, and they were not overcrowded.
Accueil SAMU du CTA, ne quittez pas, le permanent et du SAMU 67 va vous répondre.
C'est la police de... Pas 80, hein. Ouais, c'était un point de vue. T'as été voir un exemple? Moi? Oui. Non. Je te charrie. Dis-moi, donne-moi le numéro. Alors, mais enfin, la dame que je vous dis, c'est vous lui conseiller de faire en plus. C'est vrai? Ouais, elle a appelé la police. Alors, parce qu'elle a la grippe. Je sais pas, mais elle m'a dit elle va mourir. Oh, ça s'entend, hein, elle va mourir. Allez, dis-moi le numéro.
So what kind of bias can you identify here? Any answer?
So we have an answer here that says the biases that go with the policewoman thinking, first diagnosis, this is nothing.
Exactly.
This must be nothing. She's going to die, that this must be nothing. So I guess what people are saying is that the bias is right away that this is going to be nothing, that there's an exaggeration.
Exactly. So this is
anchoring. We have a term, anchoring bias.
Exactly. That is exactly that. So that means that the police operator has put in the mind of the emergency call department that, in fact, this woman may be simulating her and over-representing her pain.
Alors, au 0666, ouais. 82 67, ouais, 41, ok. Strasbourg, 10 rue de la Tumeno. 10 rue de la Tumeno. CH. Hein? CH? Ah, CH. Ouais, mais c'est du chat. Tumeno, ouais. Au 3e étage, là. Ouais. Alors, le nom, j'ai compris, Mutenga, M-U-S-E-N-G-A, je lui ai été appelée, après, maintenant. Ouais. Elle a 22 ans, elle a des douleurs au ventre. Ouais. Bon, la sérène, je ne sais pas ça, apparemment. Ouais. Elle a de la fièvre et elle va mourir. Ah, ouais, c'est sûr que...
What kind of, have you identified the type of bias right here?
There's a comment
So maybe
here. Is this based on the type of patient or is it because she is young? So that's kind of one of the questions that's coming up. Bias
Sorry.
because, yeah.
Yes, she's young. So it may not speak to you, but by the name Musanga, she's a Black woman. So even if the operator had no picture of the woman, so no video call. And
attribution or halo.
Exactly. So that's stereotyping or halo effect, halo bias. And also you may, so I may be over interpreting, but if you listen to what the way they have been speaking, we can start thinking of early closure bias. So that means that because of the entering bias, the medical emergency operator is not really listening to what and maybe they have the same attitude, not really listening to what the police operator is telling about the description of the case.
Elle va mourir un jour. D'accord. Faut qu'il mourra. Ah, ça marche. C'est la bonne. Ouais. Oui, allô? Allô? Oui, qu'est-ce qui se passe?
What do you think of the tone of the emergency department operator?
There's a comment here, the tone is violent. I guess it's certainly impatient, condescending.
Exactly.
Horrible, yeah.
So I think she has stereotyping or attribute bias. She's honestly, when you listen to her tone, she's rude to this woman. She's being rude, yes.
Bon, si vous ne me dites pas ce qui se passe, je raccroche. Hein. J'ai très mal. Oui, vous observez ça. Hein? D'accord. Voilà, je respecte. Vous pouvez pas? Ah non, vous pouvez appeler les pompiers, mais vous pouvez pas. Oui, vous allez mourir. Simplement un jour comme tout le monde. Ok. Vous appelez SOS médecin, c'est 03 88 3 fois 75. D'accord? Vous avez compris?
Have you noticed any changes in the way she's speaking? So the emergency medical department is speaking to this woman who called the emergency department.
So there's a comment here that she's very dismissive.
Yes, but she's less aggressive, but nevertheless, she does not at all reconsider what was her first impression that this woman is simulating.
88, 3 fois 75. Je vais vous aider, je ne sais pas ce que vous avez. J'ai très mal. Oui, et j'ai très mal au ventre. Oui, vous n'avez pas le ventre. J'ai mal partout. Oui, ben vous appelez SOS médecin. 03 88 75 75 75.
So there's comments here that she did not do, oh, sorry.
03 88 75 75 75.
So the procedure in France, when you call the emergency medical department, is that you are in contact with an operator who is not a health professional, but who is trained to make the call, and they have to take the decision. So they can take 3 types of decision. First, they can send right away an ambulance. They can tell the patient to call a doctor. It's what happened to this woman. Or she can pass on put the phone through a medical doctor who's going to assess the case. So you know the end of the story. So you know the fact that this woman died on that same day. But I, as a physician, listening to her voice, do you think that she was simulating? Personally, I don't. I think that she really was really painful. So this was an extreme example, but showing that cognitive bias may have a very, very significant negative impact. And it is even thought that the cognitive bias are responsible for more medical errors than the absence of knowledge. Because by definition, this is at the unconscious level, and it has nothing to do with your knowledge and with the fact that you're very good, very well-trained medical doctor. So this is the implicit bias which were involved to my understanding. So how to reduce the cognitive bias? I'm close to the end. To minimize the cognitive bias, a few specific strategy can be used to minimize. The first, of course, is to be aware that we all have cognitive bias. Either you want or you don't want it, we all have cognitive bias. So the question is that at this point, when you have a first diagnosis, you can insert a pause for formal reflection and asking several questions. If this is not a work diagnosis I've made, what else could it be? What are the most serious disorders that could be involved? And if there is no evidence to contradict, if there are no evidence to contradict the work diagnosis, and this question can broaden the differential diagnosis to include things that may have been ruled out. So there's need to create an awareness, to raise awareness among health professionals, to train and to simulate the awareness among health professionals. So that is a quite complex algorithm, but the main thing is that we need to know that we are all biased, and we need to work on the way to reduce this bias. And when this case was assessed by the Ministry for Health, they made some suggestions, right suggestion and semi-good suggestion. They said that we need to work on procedure, we need to rely on technology. The point is that it's not a matter of procedure. You may have the best procedures. If you do not consider the fact that you may be biased, then no single procedure will be able to prevent this cognitive bias. You can go on the our website to find the implicit association test, and you will be able to self-test your implicit bias towards different type of subgroup of patients. The use of technology like artificial intelligence is unlikely to really overcome all of the bias, because the artificial intelligence is trained by people who are themselves biased. So that means that it has been shown that even RA can be contaminated with bias. Until implicit bias are brought into the realm of public policy, they will not be considered, as there are so many other challenges facing our healthcare system. So that means that it's really the hidden part of the iceberg, but this is a very impactful problem on the healthcare decision. Thank you for your attention.
Thank you very much for sharing with us bringing to us this very important topic, and for your presentation, very comprehensive presentation, and obviously for this very sad example. There's just a question about the example, I guess, just to close out the case. What were the medical legal consequences? Did anything happen after this case with respect to the individuals, I guess, involved?
No, in fact, nobody was. So, as you mentioned, the woman died because of small bowel infarction of venous origin. She may have been saved. We don't know. This is not absolutely sure, because she had a massive small bowel infarction, and nobody was blamed. Because no procedural error was recognized. And this is what I published this article with one of my colleagues, because the health inspection did even not consider this part of the problem. And I really do think that most of the factor which drove this code to be not properly managed was because of bias.
There's a comment here about not even a procedural error. Did they recognize that there was procedural error involved?
No, not at all. What they recognize is that we had a heterogeneity in the way the operators were trained. They recognize that there is a need to uniformize, so to unify the way the people are going to be trained. They recognize that we need to have a more medical operator, but they did not recognize any procedure, even the fact that the call was not transferred to a medical doctor.
That's really unfortunate. Yeah, a question for you. There's just quite a few comments. I think people are quite shocked about the case because, there weren't even really any questions asked to the patient, meds or no detailed questions asked the patient. So I think there's quite a bit of surprise in the chat here about the case in particular. And people would like to try this same exercise on some other patients that they're aware of. I'm just telling you what's in the chat. A question for you about, does this change with different generations as this evolved? Are the younger people, our residents or our medical students, more sensitized? And I ask that because we're in an academic institution where often you have different generations. You have the senior physicians rounding on a service with perhaps a senior resident and then a medical student. And is there any kind of protection that comes from having sort of teams from different generations being involved? Is there any data on the evolution of these biases as the younger people are coming into practice?
No, there, to my knowledge, there are no data, and honestly, we all have the same bias. This is part of our the way her brain is functioning. So there may be an improvement with the younger generation, maybe in North America more than in Europe, because in Europe we absolutely do not consider this implicit bias. So that means that if you don't do something to work on this bias, you would not improve the way you're going to handle them.
So what you would
we may have different explicit preferences or stigmatization between the young and the old group, but we have the same. Not everyone have the same, but we all have implicit bias, and this is true across all generations.
Fair enough. So what would you recommend to us that we do? Obviously this is a very thought-provoking lecture and a very important lecture. What would you recommend that we do? Is this something that you would do at the level of the Faculty of Medicine or in the hospitals for the clinicians? And how would you proceed to sort of see if we can improve our biases? If you had to walk us through it.
I think the first thing is to raise the awareness. If you don't know that you're biased, you're not going to deal with that. My wife is an oncosurgeon. When I thought about this, the fact that we may have bias and we may not treat the patient the same way according to the bias, she told me, but we have a common discussion to decide on how we're going to treat the patient. And she said, but maybe we're not going to explain the treatment the same way to the patient based on our implicit bias. And the way you're going to explain the treatment may have a very significant impact on treatment adherence. So that means that if you have the best procedure, if you do not pay attention to the fact that you're biased, you will not be able to reduce the impact of bias. So I think the first is to be aware of all the type of bias, and this is what I've suggested. So when you have reached a diagnosis, then you need to take a pause and to say, okay, I may be biased, I may be wrong, and ask some very simple question to make sure that you are not being biased. And the way you're going to behave with your patient, honestly, that's very difficult, because I think that we all have bias and preferences, and we may all behave differently with different patients. And I think knowing that this will have a very significant impact for the patient health outcome is a way maybe to deal with this bias.
There's quite a few comments in the chart. We have 2 minutes left just for this one last question here. How can you, in some unusual cases, differentiate implicit bias from clinical acumen? I see how in some cases they may be misinterpreted for one or other.
So implicit bias from what? From
the clinical acumen.
So the way to work on that is you have some tests to assume that you're biased. So I show you the pictures of women and the intrauterine contraception. So you have example that can be used to prove that there's things that are at the conscious level and things that are the unconscious level. Once again, you may know that you dislike a given group of patients, and this is racism. This is stigmatizing. This is not bias. And you need to ask your explicit preferences, and then you may look at how you've been working and behaving with patients, and that may be a way to make the difference between what is bias and what is not implicit bias.
Thank you very much. There's a comment here in the chat. Joyce has recommended a book, Thinking Fast and Slow by Daniel Kahneman. And there's quite a few comments in the chat, a lot of positive feedback coming from the chat. I invite you Dr. Bardou, to please look at the chat. I will have to close out the meeting because it is 1 o'clock, but this looks like it was, well, I know it was a very greatly appreciated lecture. So thank you so much for bringing this topic to us today, and very thought-provoking, and clearly a lot of work that remains to be done. So thank you for sharing this with us, and thank you for everybody in the audience who participated for all your answers to the questions. Greatly appreciated. I wish
Pleasure was
everyone
mine.
today. Thank you. And Dr. Bardou, I invite you to look at the chats. There's quite a
Yes,
few comments
yes,
there
yes.
that I will leave for you. Thank you so much for being here today. Bye-bye.
Thanks to you. Pleasure was mine. Bye-bye.